Hello guys, a very good evening. Sorry, good morning. Apologies for the delay. Okay, so something had to go haywire. Just give me a second. So how are you guys doing? How has your day started? Hopefully it's doing good. All good? So let's start the discussion with a very non-formal discussion that what have you planned for today and what are you going to do for the, good morning Swati, and what are you going to do for the upcoming February? How many of you are going to give this NEET PG exam, this exam at the March? If I may get a heads up, that might be helpful for us to kickstart the discussion. Because I wanted to do two things today. Obviously discuss a few questions today and also discuss about how to do or go with your prep in the last 1 month. Can any of you say that if any of you are preparing for this exam, can you give me a heads up? That's fine. I'm not going to ask you how much you've prepared. I'll just ask how it's going. Just an informal discussion to start with. No one wants to do? Okay, great. Fine. So if you're going to prepare for this upcoming NEET exam March, just a few updates for you, so you can actually plan the next month, right? To start with, there are going to be lots of free tests given for you in Unacademy. There'll be GT, there'll be a national-wide mock test as well. I want you to use it judicially. Please use the test. There'll be PYQs on every day. There'll be study with me series. I want you to use the test. And if you have any doubts in any part of the test, you can contact any one of the educators in the Unacademy NEET PG Telegram group, or you can contact me personally. I'll help you to go ahead with the test, fine? And if you are preparing for the next or upcoming years, you can use this Unlock 20 subscription, so that it might help you in the upcoming year subscriptions, fine? Okay, so just a thing, don't give too many grant tests in the next month. Don't read any new things in the next month. Revise first. Even if you're not completed any chunk of subject, it will be a futile exercise to read it from the first now, as of now, right? So here in the last month, you're going to consolidate whatever you're going to read, whatever you have read previously, because just reading once is not going to get you the correct answer in the exam. Maybe a little bit of extra effort. If you, for example, if you're not read ophthalmology for an example, I would say that don't read it completely. Instead, use 1 hour per day to complete the pending syllabus, and rest of the predominant time for revision. Use like this: 60% of the time use it for revision, 10% of the time use it for reading new stuff, 30% of the time use it for solving an MCQ. Because solving an MCQ, analyzing the MCQ is more important at this point of time, right? So hopefully all of you will clear the exam in flying colors and you'll get the seat of your choice, right? And there are a few special batches which is coming for the upcoming month, and if it helps you, that will be great. If you can subscribe to Unacademy, if you don't have any code, you can use Pathocups, right? So today, let's start with today's discussion. I'm going to have a couple of questions today. Today we'll be having discussion at two things. One will be at 10 a.m. Unfortunately, I came a little bit late today, and one at 3 p.m. Right? So I'll be trying to cover a few MCQs, mix it back all over the place, all over pathology, fine? Okay. So I wanted to comment the answer. Read the question carefully and do comment on the answer, and then let's take ahead and see how I can solve a question without knowing much about the theory, right? That's today's entire idea in both 10 a.m. and 3 p.m. Fine. I want you to comment the answer. Please do comment the answer. Okay, anyone wants to comment the answer? The Alpha Doc and Swati who have commented till now, your guesses? or the right answer? Okay, Anjali has gone with C. Anyone wants to add to that? It'll be great if you can comment. It's fine if you make a mistake. It's completely fine. Great, Tara. Okay, we'll read through the question and we'll see what could be probably the right answer. A 40-year-old person, good Akshit, rushed to the emergency department after being involved by a motor vehicle accident. He has lacerations on the right arm. Right? This is one of the important questions. The clues for me here. There's a laceration. So when I say laceration, am I right in saying that should have been a tissue loss? You must have seen laceration during internship, or some of you might have got it as well, right? Definitely there's going to be tissue loss, right? And also some minor abrasions. The resident on call quickly manages with proper care of his open wounds in the emergency department, and the patient is admitted for daily take care of the daycare wounds, right? His lacerations begins to heal with proper and occasional debridement. See, this is again an important clue. Let's assume there's a normal part of the body, your hand or foot, whatever it is. I'm having a tissue loss, which is going to be like this. I'm having a gap, there's a tissue loss here, right? So that tissue loss, whatever has been there, is being removed properly, adequately taken care, and intermittently again debrided, right? Occasional debridement. So let's say that I'm having a proper wound. It's healing without any disturbance. That's going to be by primary intention, like a normal simple suture wound. When you shave, if you've shaved, if you're a guy and you had a cut, that's a simple cut wound, right? Or when you cut something, you cut your finger, that's a simple cut wound. I don't occasionally debride that. When I don't occasionally debride, I leave the wound to heal on its own without any intervention. That's going to be healing by primary intention without much, actually it's not without, with granulation tissue formation, right? So I'm not going to disturb any wound, it's automatically going to heal. But here, there has been a laceration, wound healing has happened first, and occasionally I'm going to debride the wound. The best example for this scenario might be a diabetic foot ulcer. I occasionally debride it, though not an ulcer, I occasionally debride it. Whenever you occasionally debride this, like all of you guys said, it's going to be healing by secondary intention and deposition of large amount of granulation tissue, fine? The first option might not happen, right? I want you to answer in which scenario you will see option A, because we'll read about other options as well. In which scenario you're going to have abundant lymphocytes accumulating during the healing process and forming a granuloma. Which process will have that? I'm sure you know the answer, and again, many of you guys wrote the correct answer, so please comment on this as well. Where you will see option A. Swati, tuberculosis is correct, but I'm talking about an wound healing. I want some answer in relation to wound healing. TB obviously will have, but anything in relation to wound healing? Because I don't expect tuberculosis in an wound, right? Anything in relation to wound healing? Can it be an foreign body granuloma? That's possible. It's a granuloma. When I'm having a wound, when I'm having a laceration, that could definitely be a foreign body stuck in the wound, which can form a granulomatous reaction. So option A could be a foreign body granuloma. Second possibility, how many of you here have put sutures? How many of you have really put sutures in your real life during internship or something? Most of you might have done, right? So one of the important possibility of an wound granuloma is suture granuloma, right? Keep this in mind always. When you have a granuloma in a wound healing site, it could be a foreign body, like any dust particle entering into it, or a vegetable matter entering into it during an injury, which cannot be taken care of my body, or suture material. I had put a normal suture. Once I remove the suture, I left tiny particles inside. Let's say there is a tiny particle of silk which stays inside. That will not be removed by the macrophage, that causes a granuloma. This is one of the important things for non-healing or non-healing of a proper wound, right? It's very, very important from a surgical point of view. I should not leave any foreign body. That's why I have to occasionally debride. Because if a granuloma forms, this obviously is going to cause a delay or an altered wound healing. That will definitely cause a delayed or an altered wound healing. That's not going to be good for the patient as well as the surgeon, fine? Okay. Second option, the formation of granulation tissue not affected by blood sugar or decreased circulation of blood. This is not possible, right? Any granulation tissue will definitely require your proper blood supply, and if there is an increased blood sugar, diabetic vasculopathy of that sort, your granulation tissue definitely will be delayed, fine? So I think coming back to your question, In this question, the person needs frequent debridement. See, it's not about frequent debridement. It's a lacerated wound, right? For any laceration, if you have seen in real life, I cannot determine that, okay, this patient has a laceration, I'm going to debride 3 days a week. It's not going to be like that. It's totally based on an individual case-to-case scenario. You have a laceration, you clean the wound completely in the first go, there's no other extra material, wound is healing properly, I don't debride at all. But I cleaned the day 1, day 2 or day 3 looks like some pus point. I have to debride again because pus means dead tissue is there, I have to remove. So I have to manage it based on a case per case basis. I cannot generalize a term that I have to always frequently debride for every laceration. Fine. I hope you got the point. Okay. Right. So I'm going to show you 3 images and I want you to comment. Everyone here, I want you to comment whatever comes to your mind first. What is this? It's fine if you're wrong, but I want you to comment whatever comes to mind first. I'm sure you will be right. What is this finding? It's a classical finding, like most of you guys have already told it. It's a granuloma, perfect. A non-caseating granuloma is great. Ravi, that's also correct. I do have an accumulation of lymphocytes, right? I have a perfect in the center. I want to add one more thing to whatever Ravi said. What are the cells seen in the center? If you have to call them, what are these cells and what are these cells? Let's mark it 1 and 2. What do you think 1 is composed of? Yeah, it's a perfect granuloma. What is 1 composed of? 1 is composed of your pink color cytoplasm, elongated cells, nuclei. That's your epithelioid giant cells, right? Perfect. This in epithelioid giant cells. Perfect. It's looking like an epithelial cells. Epithelioid cells or an activated macrophage. Both means one and the same. Fine. They are ultimately macrophage. Okay. Perfect. What does 2 indicate? You can see there are tiny ones. That's what Ravi has said initially. Those are lymphocytes. Right? Those are normal lymphocytes. A granuloma formation will have your epithelioid cells or giant cells in the center, and that will be surrounded by obviously by lymphocytes, right? So I'm going to ask few questions in relation to granuloma. I'm sure you know that these are just for revision. So if you know, do comment. If you make a mistake here, you will never forget. In a real exam, it will help you for sure. Fine. The first question: which is a principal cell for a granuloma? Giant cell or epithelioid cell? That's my first thing. The principal cell for granuloma is giant cell or epithelioid cell, because there's a confusion surrounding this. I wanted to get it over now. The principal cell for a granuloma is always an epithelioid macrophages. It is not a giant cell, right? Because giant cell is nothing but accumulation of epithelioid macrophages. It's just a congregation, right? So epithelioid macrophages or your activated macrophages is a principal cell of a granuloma, right? Great. Second thing, if I am going to see a patient with a non-necrotizing or a non-caseating granuloma, what should be your first possibility? Non-necrotizing or a non-caseating granuloma. I'll just write NN granuloma for a non-necrotizing granuloma. What should be your first diagnosis? I'll come to other things as well. At least the first diagnosis. Non-necrotizing granuloma, the first diagnosis should always be no. We have been going through this again and again. The first diagnosis should always be tuberculosis. Anywhere you see non-necrotizing granuloma, my first possibility has to be TB. Be it necrotizing or be it non-necrotizing granuloma, it has to be only tuberculosis, nothing else. Keep that in mind, please. If you have other findings like I will think of sarcoidosis if I'm going to have hypercalcemia. We saw in the last lecture a few things about sarcoidosis, right? Hypercalcemia, or you have an elevated ACE enzymes, or an erythema nodosum by skin involvement, something of that sort. I will think of sarcoidosis. Otherwise, always tuberculosis, right? TB can cause both necrotizing granuloma, that's caseating, or a non-caseating granuloma. Both are possible. Keep that in mind. Fine. Third, there are a few special types of granuloma. We'll look at that as well. Fine. I'll show you one more image. Tell me, what is this? This is a biopsy from a bone marrow. This is a bone marrow biopsy. I'm writing BMBX for bone marrow biopsy. And it's a very classical granuloma. I'm sure you'll be able to pick it up. Tell me the name of the granuloma and tell me where do you see this. There are 2 questions here. It looks exactly in a way it has to look. I'll just highlight the granuloma maybe here. There's a fat vacuole in the center because bone marrow will obviously have fat. Name this granuloma. No, this is a particular shape. Name this granuloma. You know this granuloma. Does it look like anything which we eat? It has a shape. Anything like which we eat? It looks like a donut, right? So this is a donut shaped granuloma. If you want to call it DONUT or DOUGH, NUT, whatever it is, right? It's donut granuloma. When I see a donut granuloma, there are two places where donut shaped granulomas are very common. One is bone marrow, other one is liver. These are the places, organs where donut shaped granulomas are very common. So now we know it's a donut shaped granuloma. Tell me the etiology. Donut shaped granulomas are very common in one particular disease. Tell me the disease as well as the organism involved in the disease. I'm sure you know the disease. What disease is that? It's seen in Q fever? Yes? No. It's in Q fever caused by Coxiella, right? Donut shaped granuloma it's like a spotter. If you see a donut shaped granuloma with a central hole, most of the time the hole will be made of fat vacuole only. You call it a Q fever. Look for the option of Q fever or something like that. Now, CMV will not cause a granuloma staphylococcus. CMV will cause your intranuclear inclusion. Bartonella divia, a Q fever is caused by Coxiella bruneti, right? Bartonella species causes one more disease. We'll look at the disease soon, fine? Okay, so I'll show you one more special type of granuloma. Look at the granuloma and tell me whatever comes to your mind, fine? What is this granuloma? Anything which comes to your mind, but I want you to comment. Again, it's fine if you make a mistake. How does this granuloma look? Anything unique, shape-wise, color-wise, anything unique? Great, Dinesh is correct. It's look different, right? It kind of looks like a star. Not exactly like a star. Maybe like my star, which is very, very bad. Right? It's a stellate-shaped granuloma, right? Perfect. It's a stellate-shaped granuloma. So now I'm going to have a few leading questions. There is one unique finding regarding a stellate-shaped granuloma on a microscopy. We'll see that as well. So first question is, which infection or which disease you see stellate-shaped granuloma? It's a star-shaped and irregular granuloma. That's more than enough for me. So I'm going to see stellate-shaped granuloma in case of your cat scratch disease. And like Divya said, cat scratch disease will be caused by your Bartonella henselae, right? And it's going to be caused by Bartonella henselae. Bartonella henselae will actually cause one more disease as well, bacillary angiomatosis. But cat scratch disease will have this finding, your stellate-shaped granuloma. One more unique thing about this granuloma is, when I take any granuloma for that matter, am I right in saying that granulomas will not have neutrophils? They are chronic process which primarily will have your epithelial macrophages, giant cells and lymphocytes with or without necrosis, right? This is the granuloma. In microscopy, you can have neutrophilic abscess. This is very, very unique about this granuloma, right? You'll have a neutrophilic tiny abscesses in the microscopy. This is a low power microscopy, so you cannot appreciate the neutrophilic abscess. But when you go to higher power, definitely there'll be lots of neutrophilic micro abscesses seen in this granuloma. Again, Swati, it's cat scratch disease more common in the subcutaneous tissue. There's no specific site for this granuloma. Any organ which it's getting involved by cat scratch disease can cause this. Fine. Okay. So these are few special types of granuloma, right? So I'll give you a few, something for us to think about the necrotizing and non-necrotizing granuloma. Because when I asked about non-necrotizing, quite a few of you told it is sarcoidosis, right? Dinesh, yes, silver stain. I'll tell you the concept of silver stain so that you can expand your realm of your, apart from H. pylori and cat scratch disease, right? So I'm sure most of you must have heard this from your mother. When I use silver, any silver ornaments or your vessels or utensils, when you keep outside in the air, what color will silver turn into? This is a very, very simple thing. I want your help from this so that I can tell you exactly everything about silver stain. Where it will, what color it will turn to. Anything in silver will turn into black color, right? So the basis of every silver stain is black color. So why I have to turn something to black color is, let's assume this rectangle what I'm drawing is the field of my microscope, right? It's a field of the microscope. You must have seen microscopes in your second year or in MBBS. Every microscope, the background is going to be white. So if I draw even a tiny line in the white, it looks very, very bright for me, right? It's a contrast color. So in other words, I am going to stain something black in color, which is not normally visible in a light microscope. Again, I am going to ask you one help. Tell me what things will not be visible in a normal light microscope. A structure which is very thin or a structure which is very thick, which I will find difficulty seeing in a microscope. A thin structure or a thick structure? Obviously, it has to be a thin structure, right? If it is a thin structure, it will be difficult for me to look under a microscope. So what I do is, I'm going to add silver to the thin structure, make it black in color. So if it is black in color, the contrast is perfect. I can look at it, right? Perfect. So this is the basis of your Warthin-Starry stain or your Steiner silver stain. Both are silver stains, right? Great. So now tell me, is it only Bartonella or every Treponiums or every spirochete can be stained by silver stain? Is that correct? Can every spirochete be stained by silver stain for the ease of diagnosis? Yes. So the role of silver stain is thin structures. Your spirochetes, your Bartonella, your Treponema pallidum, the syphilis, any spirochete is very, very thin for me. I'm going to use silver stain to it. H. pylori. If you remember H. pylori organism, you must have read as a slender S-shaped organism. Anything thin or slender, I'm going to use silver stain. That's all. It's not just for organism. Am I right in saying that elastic fiber is very thin? An elastic fiber obviously is thin, right? So I'm going to use it for elastic fiber. Iota staining. There is a staining called as an VVG. That's also a silver stain. I use it for your VVG. Calcium deposits, the calcium crystals, they are also very tiny. I use a stain called von Cosa. You must have read about von Cosa for sure, right? Von Cosa actually is also a silver stain. The base is a silver stain, that's all. Reticulin stain, again thin fiber. I use silver, right? Just remember the concept. Anything thin, anything very tiny in a microscope, I turn it to black color. I can easily appreciate with silver stain, fine? Hope that solves your doubt and you won't have any more doubt regarding silver stain, fine? So my understanding is, if something is tiny, we turn it black in color for silver, right? So coming back to our base topic of granuloma, okay, this will help you to solve few questions when you're stuck. I'm just going to give you an easy way to differentiate necrotizing granuloma and a non-necrotizing granuloma. Why this difference is important is, in an MCQ you should not get stuck. Our main goal is to solve an MCQ as well as to go ahead and have a good diagnosis, right? Sure, I'll do it, Swati. Fine. So let's see here. A granuloma. Tell me, what does necrosis mean? A very, very basic question. What do you think? What does necrosis mean? Am I right in saying that necrosis is a dead tissue? I'm going to ask very basic questions. Definitely you know the answer. Necrosis is a dead tissue, right? So when I'm going to have a necrotizing granuloma, am I right in saying that that disease process should cause cell death? Yes. Only when the cell is dying, I'm going to have necrotizing granuloma. Yes. When I'm going to have non-necrotizing granuloma, which means I cannot kill the cell, I cannot kill the etiology, right? I am also right in saying that granuloma is nothing but a protective mechanism for me, right? It's a protective mechanism for my body to eliminate an organism. Let's take tuberculosis for an instance. Can my body destroy or kill a tuberculous pathogen? Possible? Not possible? Possible. Causes necrotizing granuloma, right? That's why it comes here. Can my body destroy coccidiomycosis? It can. Can my body destroy or kill or necrose your histoplasmosis? It can. Leprosy? It can, right? So if it can destroy something like coccidiomycosis, histoplasmosis, and one type of leprosy, especially called as pure neuritic leprosy, right? If my body can destroy something, all of them will cause necrotizing granuloma only. I'll go to the other one, non-necrotizing granuloma. Again, I want your inputs. We saw suture granulomas, right? Suture material, silk. Can my body destroy a suture material? Can it or can it not? Or is a suture material already dead? It's an already dead particle, right? A foreign body. My body cannot go and destroy there. Sarcoidosis, it's an autoimmune disease. I don't have any pathogen to kill. When I don't have any pathogen to kill, it will cause necrotizing granuloma or a non-necrotizing granuloma. It's simple, right? So a simple concept of non-necrotizing granuloma is there is nothing to kill there. If my body has nothing to kill in any place, in any pathogenesis, it will result in a non-necrotizing granuloma. If this distinction is true, let me put ahead a question I want you to answer, so I'll be more happy that your conceptual understanding is correct. A patient with an co-worker's pneumoconiosis, if they have to have a granuloma, it will be necrotizing or non-necrotizing. It's a very common and a simple question. Co-worker's pneumoconiosis, necrotizing or non-necrotizing? Coal particle is an inorganic dead particle. It has to be only non-necrotizing, right? Perfect, that's all. So we know the basis of classification of a necrotizing granuloma and a non-necrotizing granuloma. That should be more than enough. You can apply this to any question which comes to your exams, right? Now I'm going to tell you, ask you one more different thing, tuberculosis, right? So when I have tuberculosis, again I'm going to ask your help because you are going to answer everything because you know everything. The only problem is you are not confident that you know everything. So let's say I am having a patient with the tuberculosis. The body immunity is trying to destroy the TB bacilli. Is there a possibility in a patient who is immunocompromised, less immunity, the body will not be able to destroy TB bacilli? Possible? Yes. So if a patient has a less immunity or not good nutrition or an HIV positive person where the body cannot destroy TB bacilli, will it cause necrosis or it will be non-necrotizing? It obviously will be non-necrotizing, right? So I'm just going up. This is where we discussed about tuberculosis. I'll just erase this for a second, right? So when I take tuberculosis, my understanding is simple. It's totally based on the immunity of the patient. If the immunity of the patient is good, which means that my body can eliminate the TB organism, it causes necrotizing granuloma. If the immunity of the patient is low, my body is not able to eliminate it, it's going to cause a non-necrotizing granuloma. Again, why I said when anywhere it is a non-necrotizing granuloma, think of tuberculosis. TB was a sarcoid. TB versus co-worker's pneumoconiosis. Any day, TB is the most common thing, right? Because of the commonality, any day I'm going to think that this should be my first diagnosis. I will do an acid-fast bacilli. If that is negative, maybe I'll think of other diseases, right? So I hope that you won't make any mistakes on granuloma from now on. It's a very simple concept of granulomas. Please apply this. Most of the questions you will solve. Even if you have a question which you are not able to solve, in a real life you will solve most of the troubles with these things, fine? Okay, let's go to the next question. Tell the answer, 30 seconds time. I'll explain your doubt, Dinesh. A very good doubt. Answer, guesses. Anyone wants to tell the diagnosis, they can start with the diagnosis and then go ahead with the answer. I want you to comment. It's fine if you're wrong. Okay, option B. Dinesh started with the option B. Anyone wants to add? First, tell me the diagnosis. What do you think is the preliminary diagnosis? A 10-year boy with... Okay. I'm having different options here. Let me give you one more history so that it will be easy for you to go ahead with the diagnosis. A 10-year boy with fever and everything. The boy was given aspirin. Okay. This is a simple clue for you. Now, anyone wants to modify the diagnosis? Boy was given aspirin. After that, all of these happened. So, will we think of Wilson's disease for a child with an aspirin and having an hepatic damage, or will you think of a Ray's syndrome, right? Perfect. So it's a Ray's syndrome. Now tell me what is the diagnosis. Answer. So your diagnosis is straightforward, easy now. So tell me what is the answer. In histopathology of Ray's syndrome, I'm going to see your microvesicular steatosis with mitochondrial swelling. It's option D. Fine. It's always option D in Ray's syndrome. We'll go to Ray's syndrome. Why microvesicular and mitochondrial swelling is very, very important in Ray's syndrome. And before that, we'll have to go and address Dinesh's question. It's a very good question. In a vasculitis, how can I see necrotizing granulomas? Can any one of you explain this? In a vasculitis, that's a very, very good question. Why there is a necrotizing granuloma? Okay, Dinesh, I want to ask a leading question. Which vasculitis do you think you will have necrotizing granuloma? Which type of vasculitis will have necrotizing granuloma? Any clues? Any examples? Let's take vaginous granulomatosis. Vaginous will have a necrotizing vasculitis and granulomas, right? So when I say vasculitis, any vasculitis for that matter, am I right in saying that there will be fibrino necrosis present? For any vasculitis, will there be a fibrino necrosis? Because it is destroying a vessel wall. Yes? Right? So when I have a vessel wall here, let's assume this is a vessel wall. In this vessel wall, I'm already having a necrosis here, right? I'm already having a necrosis. So in this necrosis, surrounding that, I'm going to have your lymphocytes and the granulomatous process going on, right? So when I have necrosis already present in the pathogenic process, fibrino necrosis is the finding seen in every vasculitis. So obviously I'll have necrosis plus granulomas. So it's just mentioned as a necrotizing granuloma, that's all. Every vasculitis will have too much of inflammation, which will destroy the tissue. So the necrosis part is actually the part of the pathogenesis. Granuloma formation here is a part of a chronic disease process, right? So these two are totally different settings, but it occurs in the same place at the same time, so it kind of gets overlapped. So I call them a necrotizing granuloma. Got it? Okay. Right. So we'll come back to this question. That's the reason why a vasculitis will have a granuloma. Right? Okay. Coming back to this question, Ray's syndrome and aspirin, right? Most of you must have read about Ray's syndrome before in your pediatrics, right? I'm going to go and have a quick look about what happens in Ray's syndrome. See, when it's going to be Ray's syndrome, it doesn't happen in every child. It happens only in few people who are predisposed to it, right? So when I'm going to have few people who are predisposed to Ray's syndrome, what happens is in them there'll be a mitochondrial dysfunction. So that's the basic problem in Ray's syndrome. Your electron transport chain will not happen properly. Mitochondria will not function properly, right? If mitochondria is not functioning properly, am I right in saying that a lipid metabolism will not be proper? Your synthesis as well as beta oxidation of lipids, because for a proper lipid metabolism, I need mitochondria, right? Obviously, I need mitochondria. So I'll have an altered lipid metabolism because at least one part of the lipid metabolism will be from the mitochondria only, right? I'll have an altered lipid metabolism. So my mitochondria of the hepatocyte will be able to ingest the lipid, will not be able to properly process the lipid. So am I right in saying that in the mitochondria, there will be lipid accumulation due to dysfunction? Will they have lipid accumulation? They will have, right? Perfect. So I'm going to ask you one more question again, a very, very simple question. Let's say that this is a normal hepatocyte, fine? A completely normal liver cell. In this liver cell, there will be one mitochondria or multiple mitochondria. This is a very simple question. In any body, any cell in my body, will there be a single mitochondria or multiple mitochondria? Has to have multiple mitochondria, right? So every cell in my body will have multiple mitochondria. Mitochondrial genome and the mitochondria are always multiple. Nuclear genome and nucleus is always single. Perfect. So I've drawn here 5 mitochondria. So let's assume that this patient is Ray's syndrome, which means every mitochondria here is not going to function properly. Sometime all, sometime few of them. So if these mitochondria don't function properly, what's going to happen here is my nucleus again, my cell again. These mitochondria is going to accumulate more and more and more fat. So the first change for me is mitochondria will swell. And mitochondria are going to swell with fat. So if it swells with fat, what do you think will be the color of fat in a biopsy? So my first finding obviously is when mitochondria swelling. What will be the color of fat in a biopsy? It's going to be clear, right? So all these swollen mitochondria, dysfunction due to your Reis syndrome, will have fat accumulation. So this fat accumulation is going to be dispersed in my cytoplasm. If it's dispersed in my cytoplasm, it will have microvesicular or a macrovesicular steatosis. They're going to get dispersed. They'll have microvesicular steatosis. This is very, very important. The only place I want you to remember about micro and macrovesicular steatosis is Reis syndrome. Because mitochondria are destroyed, all of them swells, it becomes microvesicular. There is no point these two mitochondria or these three mitochondria will unite with each other. Mitochondria never merge with each other. So it cannot be a macrovesicular, it is always a microvesicular steatosis, right? These are very, very important. That's what happens in Reis syndrome. I'll go back. You'll have a cytoplasmic vacuole, fatty vacuolation, right, in the cytoplasm, and have mitochondrial swelling. That's a classical case of a Reis syndrome. That's your answer here. Fine. I just gave the pathogens of Reis syndrome. It's not perfectly elucidated till now. The basic thing is, I know it's a mitochondrial swelling. There are few complex of the mitochondria which gets destroyed. Again, I'm not sure exactly what complex, but definitely mitochondrial dysfunction happens. So in a biopsy, how does it look? Is like this. There are two things here. This is not a biopsy of Reis syndrome. It's a biopsy of something else. Let's assume this is an hepatocyte. I have circled an hepatocyte. Tell me in this hepatocyte, you are seeing microvesicular or a macrovesicular steatosis. We'll just start with the basic thing, then we'll go to the next. This particular hepatocyte, micro or macro? Perfect. It's a microvesicular steatosis, right? Great. So this hepatocyte here, the second one, I'll mark as 2. The second one is having micro or macro? The second one obviously is in macrovesicular steatosis, right? One is tiny, one is big. Micro versus macro. The easiest differentiating point for me for micro and macros, don't look at the vacuoles. Always look at the nucleus. I'll circle one more cell. Okay, this is one more cell. If the nucleus is in the center of the cell, micro. Again, there are multiple things here. Micro. When the nucleus is in the center of the cell, always micro. When the nucleus goes to the corner, see, this is a cell with a corner nucleus, macro, right? You have to determine only with the help of the nucleus, because you know how the nucleus looks, blue color. If blue color is in the center, microvesicular, blue color in the corner, macrovesicular, right? That's the easiest way to differentiate micro versus a macrovesicular steatosis. Fine, great. Okay, we'll go to the next question. We'll try to solve this because it's a question based on reticulocyte correction, and hopefully this will help you in future as well. I will push everything up. I hope everything is seen. I'll give 1 minute because you need mathematical calculations here. I want everyone to do the mathematical calculations and come to a diagnosis. Tell me the answer, then we'll go ahead. If you have a mobile phone, you can use mobile phone. That's completely fine. To make you a little bit exciting and to make you involved in the process, this is the formula. The formula is below. So at least now make the correct reticulocyte count. Is it so difficult to do a mathematical calculation? Any one of you guys? Okay, I'll write it. If you have a mobile phone, you can put the calculation here. See, I'll go to the question. The question is simple. It's a 25-year-old person evaluated for complaining of fatigue and passing pink colored urine, right? Lab test shows so and so finding, and you have a classical finding of an reticulocyte. I'll come to your answers, Akshit as well as Hari. Your flow cytometry shows CD55 and 59 negative. So what do you think is the primary diagnosis here? 55 negative, 59 negative. The primary diagnosis is obviously with an history of an pink color urine and everything. It's an paroxysmal nocturnal hemoglobinuria, right? Right. So however the physician is interested in finding the corrected reticulocyte count because the patient is on eculizumab. Eculizumab is one of the most expensive drugs available on the earth, and that's a treatment used for PNH as well, right? So my question is totally different, diagnosed totally different. What the question is asking is how to do a corrected reticulocyte count. If I know that, that should be more than enough for me, right? I've given you the formula as well. So this formula is going to be useful for a real life as well, because when a lab gives a reticulocyte count, I'm going to look in the microscopy, count the number of reticulocytes and give you. Some of the labs might not correct and give you, but to have an interpretation in a real life, I have to correct it. I'll tell you how the correction is going to help me, right? So this is the first correction called as an corrected reticulocyte count. After that, I have second correction, which is going to be called as an reticulocyte production index, right? So corrected reticulocyte count, the formula is the percentage of reticulocyte, that's here 6% in this question, patient's hematocrit by average hematocrit, or I can use patient's hemoglobin divided by normal hemoglobin. I can do it either with the help of hemoglobin or your hematocrit. I'll come to that as well, Swati. And I can do it based of hemoglobin as well as your hematocrit, fine. So once I use this, I'm going to have 6% here. That's my reticulocyte count in this question. Multiplied by patient's hematocrit is 32, right? Okay, great. Divided by normal hematocrit is 45 if it's a male, or 42 if it's a female. Why I want you to remember this is, in this question there is no problem. Even if you put 45, you will get more or less 4.4 or something. The closest one is 4.6. Actually, if you put 42, you will get exactly 4.6. Fine. Okay. So here it is the women. Gender also matters sometimes. 45 versus 42, there will be a slight difference. If there are very close options, you might get up in end up in a trouble, right? So male 45, female 42. Here, whatever is fine. My answer is going to be around 4.6. Fine. So 4.6 is my corrected reticulocyte count, right? We look at the second thing. We have two corrections. This is my first correction. The second correction is your reticulocyte production index, right? Before we go to it, we'll take your Swati's question. What is the need for a reticulocyte count here? Can anyone add the need for reticulocyte count here? It's a case of PNH. Why do I need a reticulocyte count? See, that's a very good question because I need a practical application for everything, whatever I do. Anyone wants to add? If no, you can say no. I'll definitely tell you the importance here. Okay, the patient of PNH has been started on eculizumab. If the patient is being given treatment by eculizumab, am I right in saying that I should expect less hemolysis or not? Should the hemolysis become low after treatment with eculizumab? Yes. If the hemolysis reduces, what will happen to reticulocyte count? Reticulocyte count should reduce, right? So this is just to assess the treatment response. Okay, there's an easier way to assess treatment response because when you give eculizumab, hemolysis should stop. If hemolysis stops, reticulocyte count should reduce. If reticulocyte count is not reducing, eculizumab is not working, I have to do something else because in very expensive drug, I have to monitor response even after every dose of the drug. That's the reason why reticulocyte count is done in patients, fine. Because reticulocyte count has both diagnostic as well as prognostic significance, fine. So we'll come to whatever Dinesh said. To differentiate between hypo and hyperproliferative anemias, right? I do have a distinction of hypo and hyperproliferative. This is the image of hypo and hyperproliferative, right? When you have less than 2.5, this is based on RPI. It's called as an reticulocyte production index. Okay. So based on reticulocyte production index, if it is less than 2.5, I call it an hypoproliferative anemia. If it's more than 2.5, I generally leave it as hemolytic anemia or an hyperproliferative anemia for the matter. The proliferation is based on the bone marrow. The bone marrow is performing more, the bone marrow is performing less. That's the only difference here, fine. Okay, we'll come to this difference soon. So how do I come to RPA? I'll definitely zoom it, Swati. We'll look at RPA, then we'll come to it, right? So this is my first correction. I need to come to the RPA. So for RPA, what I do is I take a corrected reticulocyte count. I am writing CRC for the corrected reticulocyte, whatever is 4.6, right? Divided by something called as a maturation index, right? I'm not going into the detail why a maturation index is required. I'll just tell you the values. Hopefully in your exam, they should give the values. I hope the examiners have some sense in giving their maturation index. If not, unfortunately, you have to remember it, fine? I'll go to this again, an image from Harrison. So the maturation index is based on hematocrit. If it's 45, my maturation index is going to be 1. Maturation index or shift factor or a correction factor. All the three are the same. 35 hematocrit, 1.5. 25, 2. 15, 2.5. These are my maturation indices. Actually, you need not remember this. As I said, the examiner should give it, right? So in this question, my RPA, reticulocyte production index, was 4.6 was the corrected reticulocyte count, right? That was my question. And if you remember, I'll go back once. The hematocrit of this patient is 32, right? So my maturation index in this patient will be, I'll keep somewhere conservatively around this 1.5. So it's going to be 1.5, right? So 4.6 by 1.5 is your reticulocyte production index. Unfortunately, I need mobile phones to do the calculation. Just give me a second. So it's around 3. So my RPA is around 3. So my reticulocyte production index here is around 3. That's 4.6 by 1.5. If it is around 3, so where will you put this? Hypoproliferative or hyperproliferative? Hypo or hyper? If the RPA here is around 3, it will be hypo or hyper? It will be a hyperproliferative, right? RPA is more than or equal to 2.5, it's hyperproliferative. Perfect. Now let's go back to our question. The patient is being treated with eculizumab and still there is hyperproliferation, which means still there is hemolysis. So am I right in saying that the dose of eculizumab is low? I have to increase the dose? Yes, because there is still some amount of hemolysis going there. Okay. Right. So I have to make more dose correction for that patient so that reticulocyte reduction risk comes less than 2.5. Fine. Dinesh, this is the only formula available for RPA. What other formula must have told you is this. They must have clubbed both corrected reticulocyte count and shift factor. So RPA might have been like this. It might have been like your the reticulocyte percentage into hematocrit of the patient divided by normal hematocrit divided by maturation factor or a shift factor, right? So they must have, yeah, it's not always 2. Like you said, hemoglobin by desired hemoglobin into reticount, I cannot keep it always 2, right? The maturation factor is a variable. In that question, if it is 2, the hematocrit in that question must have been 25. That's why they would have put as 2, right? So the maturation factor varies based on your hematocrit values. Right? Whatever you said is correct, but for a hematocrit of 25. I hope it is clear. Fine. Got it? So that's how we classify your anemias based on reticulocyte production index. So now where it is going to be helpful for me is, it's going to be helpful for one MCQ especially. We can understand many things about a disease. You must have read thalassemia. All of you must have read thalassemia. Am I right in saying that in thalassemia, you must have read about a terminology called as ineffective erythropoiesis? You must have heard about it. Thalassemias will have ineffective erythropoiesis, yes? So patient with an ineffective erythropoiesis, am I right in saying that the bone marrow is not able to respond to the degree of anemia? Yes. I'm having hemolysis, my bone marrow is not able to replace it, that's why I call it ineffective, right? So if my bone marrow is not able to replace or not able to function perfectly, am I right in saying that reticulocyte production index should be less than 2.5? Yes. Thalassemia is a hemolytic anemia. I would have expected this index more than 2.5, but unfortunately thalassemia will have index less than 2.5. You can look at this. You can see here thalassemia. Though being in hemolytic anemia, the index will be less than 2.5, which means thalassemia is an hypoproliferative anemia. The main reason for this distinction is treatment. If there's an hyperproliferation, am I right in saying that my bone marrow can replace whatever is lost? Can it replace? It can replace. So I'll wait and watch. For an autoimmune hemolytic anemia, I give steroids. I wait and watch. All the lost hemoglobin will come back again. In case of sickle cell anemia, I do the same thing. Except for sometimes in thalassemia, do you give transfusion or you wait and watch? We transfuse, right? So in all of these conditions, one of the primary modality of treatment is transfusion. I cannot wait because my bone marrow is not able to replace. Iron deficiency anemia below 7, I can't wait and give iron. Give transfusion first. Same goes for everything here. So transfusion becomes a mainstay of treatment if my bone marrow is not able to replace it. But other conditions, I would wait and watch to some extent because my bone marrow is able to replace it. That's the main reason for classifying them as hypoproliferative and your hyperproliferative or your hemolytic anemias. Fine. Okay. One more question. Let's see if we can solve this. Again, something based on reticulocyte count. We'll see if you can solve this. There's no formula involved here, but just to make sure if you understood the concept of reticulocyte count. 30 seconds, tell me the answer. Okay, anyone wants to answer? Okay, A. Anyone else? Swati has started the thing. Before that, diagnosis. Tell me the diagnosis as well. Megaloblastic anemia. Okay, I'll go ahead with that. Anyone else wants to change the diagnosis? Anyone else wants to change the diagnosis? No one wants to. Option A is correct. I have no issues in that. Tell me what is the diagnosis? Because diagnosis is also very important in this patient, because it might help you in other MCQs. It's not megaloblastic anemia. A is the correct answer. I do accept that. Okay, we'll go through the diagnosis. IDA, right? Sona is correct. The diagnosis based on it's an iron deficiency anemia, right? There are many pointers for here to call it an iron deficiency anemia. A 67-year-old person presenting to the clinic for progressive fatigue for the past 4 months. Diet contains fruits, vegetables and fish. So which means it has both vegetarian diet as well as non-vegetarian diet, green leafy vegetables as well as non-vegetarian. So am I right in saying that this patient will have both adequate amount of folate as well as vitamin B12 based on this diet? Good amount of diet, folate as well as B12, right? Right? Perfect. She states that she has been very healthy previously and managed her own health without physician for the past 20 years, right? So everything here is normal. So it cannot be a nutritional deficiency coming all of a sudden. But like Dinesh said, and I don't know why you deleted that message, it's perfect of an MCV being 78, which is lower. I'm having an MCV low in a 67-year elderly person who has got good amount of nutrition till 67 years of age. Obviously, a 67-year-old person, I won't think of menstrual irregularities. It must have been a postmenopausal woman for sure. So I will not think of a menorrhagia at least, right? So 67-year-old MCV being less, my probability of diagnosis is more towards iron deficiency anemia. This is not enough for me. I need to know the etiology. Because if I don't know the etiology, I might miss some things. This is for real life as well as for your MCQ. An elderly person with a diagnosis of an iron deficiency anemia, what do you think should be the etiology and what should a doctor look for? An elderly person, what will a doctor look for? Anything? I know, I'm sure you know the answer. You have to look for blood loss, right? You have to look for blood loss, not for melena. Melena might not be always present. You have to look for occult blood loss, right? Perfect. I have to look for cancer, especially colonic cancer, right? If it is melena, great. Postmenopausal bleeding also is a possibility, but postmenopausal bleeding will present to me. It will not be chronic. It will not cause iron deficiency anemia, right? Because even a tiny spotting of the postmenopausal region, the woman is going to come to a doctor. It will not cause an anemia. But an occult blood loss, when I say occult blood loss, what is the meaning is, grossly the stools are completely normal. Microscopically, daily, over the period of 2-3 years, there have been tiny amount of blood loss, like your ankylostoma, which loses 0.3 ml of blood per day. That will not alter the color of the stool. It will be the same, right? But a very tiny blood loss over the period of years, that would have caused your iron deficiency anemia. Elderly person, always think of this. Be it men or women, elderly person, think of a malignancy, because till that time they had a normal food, suddenly they cannot have an iron deficiency anemia. Do an occult blood loss. Don't go with the colonoscopy straight away. Any elderly person, this should be the protocol for an iron deficiency anemia. You suspect an IDA or you suspect a microcytic anemia. Obviously, the first thing you have to do is an iron studies. You do iron studies, you have to confirm it's an iron deficiency anemia, because without confirming, it could be an sideroblastic anemia, it could be anything, right? Without confirming, I cannot go ahead with anything. I confirm iron deficiency anemia, then I'm going to do occult blood for stool. I'll come to it. When you do an occult blood for stool, if it is positive, then counsel the patient, talk to a gastroenterologist, ask for a colonoscopy. Okay. If it's occult blood in the stool is negative, okay, if it's negative, I'm going to rule out at least colonic malignancies. Like you guys said, it could be an postmenopausal bleed. The patient is not open and not coming and telling me the diagnosis or telling me the symptom. Examine is there any other source of blood loss, right? Examine the patient thoroughly for all possible source of blood loss. If nothing is there, I'm going to fall back to nutrition. Nutrition should be a last resort in an elderly person. But for any young individual, adult, if it's an IDA, the first possibility is nutrition. I won't think like that. Yes, there is the same, like you use RBC direction for anything, even your urine, stool, whatever it is, I'm going to think of that. God gifted in an elderly, again, worm infestation for me is going to be not a first finding, right? If it's a pediatric population, young adult, I'll think of worm infestation first. I won't think of a worm infestation in an elderly person, right? And again, if it's a worm infestation, why I don't think is an elderly person, all of us, I know if it's a worm, there'll be symptoms for it. There'll be itching present, there'll be uncomfortable symptoms. So they'll come with that. So pediatric population will not be able to express that symptom, but an adult should express the symptom, right? So I will rule out worm infestation if the patient is asymptomatic, especially. That's why I'm thinking colonoscopy for a cancer, because a cancer will not have any manifestation, right? You are right in saying if it's a pediatric population, I'll think of a worm infestation for sure. Okay, great. We'll skip this question for the evening. We'll see this question. With this question, we'll call off this today's discussion at 10. We'll have one more discussion at 3 p.m. Have few more questions. We'll be discussing that at 3 p.m. as well. Fine. If you're free by 3, please welcome to join. Okay. Again, last question for today. Today's morning discussion. Tell me the answer. We'll have a very quick discussion. Diagnosis. I want the exact diagnosis. There are lots of finding given here. Okay, most of you are going with option D. Great. I'll go through it. Akshit has gone for option C. I'll read the question. There's a tiny difference between two things. See, D looks very easy. The purpose of this question is don't overlook and write DAC as the answer for any question which comes with these kind of values. Keep a differential diagnosis, right? 44-year-old person, acute distress, multiple ecchymosis, and the patient has I'll come to that as well, Swati. Prothrombin time is elevated, partial thromboplastin time is elevated, CBC shows a WBC count of 5300, normal, hemoglobin of 8.1 is less, hematocrit of 25 is less, MCV is fine for me, platelet count is less as well, right? So I'm just going to write all the information given for me. PT is elevated, APTT is elevated, D dimer is high, right? And platelet count is low, right? So I'm going to ask you a question. See, option A cannot be the answer because PT will not be elevated in option A, right? Option C again cannot be the answer because prothrombin time again I cannot expect, and D dimer again I cannot expect in your von Willebrand disease, right? So what is D dimer? Tell me, what is D dimer? What is D dimer? It's a breakdown product of the clot, right? It's one of the breakdown product of clot, right? So D dimer will definitely be elevated whenever there's a fibrinolysis. This is one important clue to call it DIC. This is a very, very specific finding for DIC, right? When I take afibrinogenemia, am I right in saying that in afibrinogenemia also PT as well as APTT will be elevated? A or a dysfibrinogenemia? Because in afibrinogenemia, blood clot cannot be formed. So will PT and APTT be elevated? It will be elevated, right? So this is a common finding for both. So D dimer also slightly there will be an elevation. It will not be very highly elevated because what happens in afibrinogenemia is I don't have normal fibrinogen. It's not synthesizing properly. So whatever tiny amount comes, it breaks. So it kind of have a confounding factor on D dimer, right? But platelet count is very, very important. So the other name of DIC is your consumption coagulopathy. It consumes everything. Afibrinogenemia, platelet will absolutely be normal, right? So it's in consumption coagulopathy, so it's just D dimer here, fine. So the reason why I want this, if you have a patient with an afibrinogenemia or dysfibrinogenemia, in dysfibrinogenemia, D dimer actually will be elevated. FDP actually will be elevated more than D dimer. FDP will be elevated, right? Because it's an abnormal fibrinogen, it will break easily and can cause your FDP to be elevated, right? So here, PT will be elevated, APTT will be elevated, thrombin time will be elevated because fibrinogen is not normal. So the step before fibrinogen is thrombin, so the thrombin time will be elevated. Platelet count will be absolutely normal. That's one important clue. And one more important clue. You know this answer. You're going to tell me the answer for this. It's fibrinogen, right? When I take fibrinogen, it's one of the important thing for one blood test to function properly. When I take a blood outside the body, it stays and it settles down. We have a test based on that. What test is that? And for that, fibrinogen is a very, very important component, which is ESR, right? I'm sure you must have read that. For an erythrocyte sedimentation rate, it's totally based on fibrinogen, right? So if fibrinogen is lost, not present or absent completely, my ESR is going to be 0. There is no fibrinogen, my ESR will definitely not, my RBC is definitely not settled at all, because fibrinogen is the one which eliminates the equal negative charge of the RBC, so makes them to form rouleau. So there's no fibrinogen, you'll have a 0 ESR. This is also a clue, fine. Just since we are here, we'll have a very quick decision, maybe a couple of minutes to differentiate about FDP and D dimer. I've told this multiple times. If you've not known that, this will help you to differentiate FDP versus D dimer so that you will not have a confusion which is specific and which is sensitive, right? So let's assume this is fibrin, the fibrin clot. The fibrin clot is a perfect, it's not a monomer, right? It's a polymer. It's like your shirt. It's perfectly intertwined. That's why it's very, very firm, right? So when I break this fibrin during fibrinolysis, which happens after clot formation, so what can happen is I can have the lysis, I'll use a different color, can break here, can break like this, can break like this. It can break in multiple places, right? So once it breaks, I can have components like this. At the same time, I can have components like this, right? If it breaks exactly the crisscross region, it forms component like this. If it breaks individually like this, that can also happen. I'll have elongated components like this, fine? I'll come to it now, just give me a second. Fine. So this entire components together, all of them together, put together, I use the term FDP. I call it fibrin because this is fibrin degradation products, which is including the tiny molecules of fibrin plus the crisscross. Both together, I call it a fibrin degradation product, right? But when I have this crisscross products alone, this products alone is called as a D-dimer. So we say that D-dimer is very, very specific for DIC. Now I'll tell why D-dimer is specific for DIC. In a normal body, you and me, I do have fibrinogen in my circulation, right? So it's fibrinogen is a protein. Can a protein get destroyed? A normal fibrinogen, not fibrin. I'm talking about fibrinogen. It's a protein like this. Can it get destroyed? It can. If it get destroyed, will it be like this? It's just broken. It will be like this. So I am right in saying a fibrinogen degradation product, that's FDP, this component can be seen after clot, can be seen in you and me as well, because it's just a protein, it can be destroyed, correct? Yes. But for you and me, when I don't have a clot, will I have this crisscross binding? This crisscrossing happens only when the polymerization happens, or the crisscrossing will happen only after clot formation. Before clot formation, I cannot have this. So can I say that D-dimer will never be elevated in a patient with crisscrossing pattern? Sorry, in a normal person without clot, it will not be elevated, right? That's why D-dimer is very, very specific. For a clot lysis, FDP is a sensitive test, which means I can say in all patients, be it normal or abnormal, if fibrinogen is getting destroyed, FDP will elevate. Only when fibrin, the clotted fibrin gets destroyed, D-dimer will elevate, right? That's why D-dimer is very, very important for, or very specific for a diagnosis, okay? Got it? Any doubt in this? Okay, Nana, D-dimer's normal range, there are quantitative and qualitative. If it's less than 0.5, it's considered normal. In pregnancy, I can have a leeway of slight increase accepted. But for any individual more than 1, that's what you must have done in COVID, more than 1, or in some units 1000, it's definitely abnormal. Fine. Clear? Fine. So fine. To summarize today, we saw about granulomas today. That's the first question. We went to wound healing and then we went to granuloma. If you have any doubts in granulomas, do let me know. We'll finish it off and then we'll go to the next chapter. And we saw about Ray's syndrome, the microcytic, your microvascular steatosis and the pathogenesis. And we saw about reticulocyte correction. I'll come to it, Swati. We saw about reticulocyte collection, we saw about reticulocyte production index, and we applied the same reticulocyte collection to an IDA, where we said how we can evaluate a patient with an elderly person with an iron deficiency anemia, and then we saw about DICs and your fibrinogen degradation products. It will not again degrade. I'm not able to understand your question. D-dimer is definitely a degradation product only. Why it should degrade again? I'm not able to understand the basics of your question. Can you rephrase it, Swati, once? Great, you like it, Dinesh. Possible to rephrase your question? Okay, if it's not possible to rephrase, can you please explain the question in the Telegram group later, Swati? I'll be able to reply. Okay, no, see, this will not become this. Okay, if that's your doubt, this will not become that, right? So what I said was, see, this is a fibrin polymer, right? So in this fibrin polymer, I can have a destruction at here, which is going to give me crisscross structure, or I can have a destruction here, which will give me line, right? So it's not that the crisscross will become line. Got it? So I can have structures like this as well as like this, because I'm just breaking it randomly, right? So I can break in both aspects. So both components can come. Both components together is called as FDP. And this component alone is called as a D-dimer. Got that? I hope it's clear. It's based on lysis. I can have different modality of lysis. I hope I was able to make some sense. Okay, great, fine. Okay, thank you for your time, guys. We'll see again by 3. Hopefully we'll be having maybe a few more MCQs an hour, and hopefully we'll learn more together. Fine. Thank you for your time. After your lunch, definitely you'll be having a postprandial dip. Just come and sit here. We'll learn together more. Okay. Thank you. Bye-bye.